very much. As I said, I'm a clinical oncologist based at Imperial Healthcare Trust. I'm currently on sabbatical, however, and I'm trying to take forward a long held and implemented passion for clinical hypnosis, which I have found very transformative, not only personally, but for many of my patients. And so I'm hoping to tell you a little bit about that. My other roles are within the RSM, the president of the section of hypnosis and psychosomatic medicine, and I've been talking around the country in that capacity as well. But I'm also founder of Tranceform Medical, which is my my wish to try and get this out there in a much more meaningful way. So it's wonderful to collaborate with so many people who are probably further along the route than we are with this. And I think maybe many of you in this room have probably heard about hypnosis in the media, rather than actually in any way through your training or education to date. And indeed, actually, it is the wider medical profession who is not sufficiently aware and somewhat held back by many misconceptions, which are often born of stage and film representation, which is somewhat scary, really. This is nothing new. We know hypnosis has been recognized in various ways. It was initially introduced across the panel by Franz Anton Mesmer, who coined, well, he didn't coin, but we've coined the name mesmerism for somebody being entranced. But it was James Braid who coined the word hypnosis, which again is a little bit of a misnomer because it's not about sleep. But when it sort of was realized that it had some really fascinating properties, many clinicians got very excited about it, one of whom was John Elliotson, who founded UCLH. And he had a couple of very highly hypnotizable sisters who he demonstrated upon. And such was his enthusiasm that he actually hacked off quite a lot of his colleagues, and they forced him to resign. So we went off and set up a mesmeric hospital that did an inordinate amount of good in an age where medicine was quite limited. But another of these clinicians was James Easdale, and he was a surgeon who had a big practice in Bengal in India. And he had a number of assistants that put all of his patients into deep hypnotic trance when they were thereby hypno-anesthetized. And he was able to undertake painless operations in an era where they had no anesthetic other than alcohol, perhaps. And he wrote back and said that in his knowledge, he had seen no bad consequences whatever arise from people operated on in mesmeric trance. Indeed, they actually healed very quickly by first intention, and in the rest, they had no subsequent problems at all, even less pain after the operation, not even a death. Now, if you look at the date, not even a death in that era was quite something, because you didn't have blood transfusion, antibiotics, and the sort of care that we now take for granted. In fact, you often didn't survive, because of your doctor. But anyway, I would put to you that hypnosis is indeed a Cinderella science, and it's time to get it to the ball. But it's an untapped resource that we really don't educate ourselves about. It is actually highly effective and very versatile. It works in the majority of us, albeit to variable degrees. And indeed, all hypnosis is actually self-hypnosis. It's a very permissive process which empowers the individual. And actually, we have a lot of evidence that it works. And there are very few contraindications, and probably more so in this medico-legally sensitive age. We wouldn't probably advocate it in people with unstable epilepsy or brain tumours and maybe severe mental health issues. But actually, it helps a lot of people across many specialties. There's a lot of basic science and investigation that show it as a distinct brain state. Indeed, it is on an EEG characterized by alpha and theta waves, not the delta waves you see in deep sleep, and distinct from our normal cognition, which is characterized by beta and gamma waves. But we can see that certain areas in the brain light up if you've got hypnotic pain relief, and that's borne out by regional changes in cerebral blood flow shown on fMRI, functional MRI scans. But we're held back by lack of education, and although there are some countries that are doing this much better, we're held back in exploring it further, which does need to be done, in understanding the mediators and moderators of hypnosis. But actually, I'm taking on the challenge of trying to develop more effective dissemination strategies, hopefully with your help as well. But what is it? Really, it is actually a very valuable tool that allows an interaction between the mind and body, affecting therapeutic changes, which actually engender coping strategies, help people to connect those innate healing forces that we're actually beginning to delineate are very much part of the mind-body connection. It's actually just a focal state of attention that's coupled with a relative suspension of peripheral awareness. And it allows an effective communication with your subconscious that actually allows you to implant therapeutic suggestions that improve well-being, which without the need to rationalize them in the conscious state. You say it's like resetting your hard drive a little bit to patients. But I think it's important to say what it's not. It's not a one-size-fits-all. There is considerable variability in the population I've mentioned, and about 10% of us will probably not be able to use this, but actually there'll be highly hypnosuggestible people, and the majority of us fall in the middle. With motivation and repetition, you can improve that. And it's certainly not a substitute for all that we know is good and effective in medical and surgical care that we obviously want to utilise too. There is lots of data in a surgical setting that show that actually it's a really good moderator of pain, nausea and vomiting, and anxiety. It reduces perioperative and postoperative anesthetic requirements, and indeed the anaesthetists are catching on quite fast now. They like hypnosis because patients are much more stable intraoperatively. They have less blood loss, they need less transfusions, and their procedures require less drugs, and they have less consequent behaviour disorders afterwards. I love this slide because Kathleen Varga was an inspirational professor of psychology who is in Budapest, and she had an alliance with her ITU specialists and did a series of 2 or 3 randomised control studies using therapeutic suggestions for patients so unwell that they were on ventilators in ITU. And there were 2 groups equally divided by severity, and the controls were treated normally. And the 2 studies she did replaced latterly those psychologists reading the therapeutic suggestions to the patients who were apparently unconscious. And she did the second lot with audio files, saving a bit of manpower. The results were the same. They got patients off ventilators on average 2 days earlier. They got them out of ITU significantly sooner. But look, those patients who got off ITU, they were so much better set up to engage with their rehab. They had less pain. They worked harder, and they had a much better feeling that they could get better soon. And indeed, patients who spend a lot of time on ITU do get PTSD, they get post-ITU psychoses. There was a lot less of that seen, and they integrated it into their own sort of journeys with less trauma. It was a real miss that we didn't put that in over COVID. I did actually try and email my colleagues, but they were busy. But maybe now we can take it forward. As an oncologist, I've been really keyed into trying to capitalise on what we know works in oncology, and we know that it helps pain, but that's really important for chronic pain sufferers. But look, it even works 2 years out. It's a really durable intervention. We get people out of hospital quicker. We need that now. And we improve people's body image, and I can very much vouch that head and neck, because that's my specialty, patients benefit. But if we can reduce depression and distress, improve sleep, which it certainly does, then we are actually improving quality of life on so many parameters. And it works in breast cancer, hot flashes, helps with needle phobias and anticipatory venipuncture, anxiety, helps people learn, which we found when we're trying to gate radiotherapy with lung motion. And I've found it instrumental in managing phobias and PTSD as most head and neck patients have to wear an immobilization plastic mask to hold them to the couch. If you have claustrophobia, that's a no-go zone. And 80% of patients anybody who's willing to work for the eye gets better. So I think from the point of view of palliative care, I think we have to include it there as well. There's data showing that it's not only able to improve a huge number of symptoms that patients coming towards the end of their life obviously have in greater number, but actually their affect, their outlook on life facing death can be fundamentally changed by the way we as clinicians can talk to them and encourage them, if only just to have a mental holiday from that angst. And that in its own right, I think, switches on a whole new set of your own immunological therapy that actually, I think, gives people a longer length of life. It's fantastic for pediatric patients. The little ones, they have such vivid imaginations, they don't really need a formal process. But hypnotic language is very, very powerful. And although there are limited studies, meta-analyses do show that this form of psychological intervention has huge scope for improvement. So we have a lot of challenges. There are randomized controlled trials. We've shown this is the best intervention for irritable bowel syndrome in drug refractory patients. And actually, how many gastro departments integrate clinical hypnosis? There's one at UCLH, though, yeah. But actually, it lags behind Europe. We lag behind the US. We have sort of less integrative care working, I think. And really, what I want to try and do is to persuade, educate our medical fraternity to just add this in as an adjuvant intervention. It's not a complementary therapy, it's not an alternative therapy, it's an adjuvant therapy. And actually, it's also going to be brilliant for us as clinicians to preserve our own well-being, because I can absolutely vouch on a personal level that is really effective. And of course, we can do this now in a better way, because actually we do now have this wonderful ability for recombinant innovation, and we have so many examples today. But I gather the guy who suggested putting wheels on suitcases was laughed out of the office. But you know, now we we know that telephones and computers go well, and we carry them around all the time. But if we could only just put in some therapeutic audio suggestion with our medicine and the digital technology that we're now using, we could have enhanced recovery. And I think that, all right, that's jumping a bit, but it's really about empowering patients. We need to actually have them much more participant in their own care. Everybody does better when they're in control. Hypnosis gives you more control. And it's actually the education and the signposting from us as healthcare professionals that allow us not only to select the patients who could best use this tool, but actually obviously identify patients who it may not work for. But actually we could improve resilience and quality of life and responses to treatment, perhaps. There's a whole other set of work that needs to be done, and hopefully integrated with proms and patient feedback. But actually, it's also really important for us as healthcare professionals, because we're in a really desperate state at the moment. We're all overwhelmed and inundated. And actually, this will buy us time for the patients we need to spend time with. That would make us feel better, because we all want to care for our patients. So we set up Tranceform Medical, my colleague Rumi and I, looking at delivering some core audio files for people. And we want to try and improve that on an organisational level to deliver improved symptom control, save bed days, and actually the health economies that we hope and know are proven. This is our website, and it's in its formative stages. We've got a long path to tread, but we're appealing both to healthcare professionals and the patients themselves. And really, I think this is the win-win-win, isn't it? I mean, the patients benefit from education in a pain setting. Just telling patients how pain works helps their pain. Take this to another level with a little bit more signposting and hand-holding. They can choose their own specialist audiophile, nurture their own self-care in a framework of less anxiety. We know this actually speeds healing way back from the 1840s. And actually, it's a huge asset and a life tool for managing stress and getting the best out of life. And that also plays out for us as healthcare professionals, for our own well-being and resilience. It's an amazing skill as a communication tool as well, and it helps build rapport, it will save time, and it enhances the placebo effect, which we use as a baseline for all of our studies, but we don't actually plumb into what that is. But we know that hypnoplacebo works better than placebo, and it reduces nocebo. And healthcare so often these days introduces nocebo effects because we have a litany of doom in every consent form, and it usually ends with the risk of death. And that obviously activates a huge fear for most of us because it's a bit taboo in the West. And of course, for organisations, really what everybody wants is to have a happy crowd of workforce. That's not the case these days, many organisations, and we want improved patient outcomes, improve bed utility, we want to reduce wait lists, lower complaints and claims, and have better compliance with the treatments that we know that work. So actually, this is a huge asset for public health as a prevention tool as well. And actually, with all the things that we've so far heard about today, these actually amplify any of those interventions, I feel. So this is something that conjoins with so many other things that people are talking about and will reduce drug costs, which is a little bit of a problem when you're trying to be sponsored by anybody from pharma. But ultimately, I think really it's all about how we all knit together and form the jigsaw that we are hopefully starting today. I think it's all about education and empowering patients. Having a much less hierarchical relationship with patients is what hypnosis is all about. And actually, I think I'm on a very steep learning curve about how we can use the digital tools that we have and now are learning from and integrating with healthcare as one of the very few things that came out as a positive from the pandemic, really. And so I think we're trying to provide webinars for both patients and healthcare professionals. We're trying to appeal to organisations to bring us on board to try and do that hand-holding from within, maybe on a specialist provider level for different services, and hopefully then actually implement a broader outreach and education where people can use that and self-sustain with mentorship groups, patient groups, to help on a wider level. So I hope I've got in with my 15 minutes, but I think that's it. Thank you.
Do we have any questions from anybody?
I've just got one. What are the blockers then? What are the things that are?
Well, it's interesting. I managed to get a couple of medical student groups to do a little sort of pilot service development exploration. And I think there is preconception still. Yeah. And an education about hypnosis. Yeah. So a lot of the stuff, I work hard to try and, affect my circle of influence. But actually, even if you have posters and flyers on the wall, people switch off to hypnosis. There's a lot of cultural preconceptions as well. Sometimes people confuse it with a religious viewpoint as a barrier. We've started calling it audio therapy a little bit more. But actually, the studies are slightly mixed on that front because there is a science to hypnosis, which actually worked for some patients. But how you integrate it, introduce it is probably very key. And actually, if it comes in on the back of other things, I think it's probably where it's going to be powerful.
Yes, and who?
Sarah, it's really interesting, and I'm keen to talk to you about my own personal requirement of hypnosis and my wife. I think the problem comes with everybody in who's dealing with a piece of technology. The technology isn't the problem; it's the adoption and the mindset that needs to change to adopt the technology.
Indeed.
And we're developing. We recognised this way considerably a long time ago. And we're developing an educational program for ourselves, but to educate doctors in adopting technology. So what are the problems, what is the technology taking place in their careers and their professions. They're dealing with their barriers to adoption, which you need to address before you begin the conversation. Then once you get that, how to actually adopt the technology into one's work practices. So you're taking them through a journey. It's all about VR and education. Nothing about the technology. It's just getting it in there.
Yeah.
And then once you've got the technology and the agreement that yes, we can use this stuff in our daily work practice, the next stage of that educational process is how do you deliver it to the end user? So you need a database very much similar to the, as we spoke to the TSA about this, Telecare Service Association, in how you get those technologies in a database that could be delivered in the same way the GP is familiar with delivering drugs. So you type in your symptoms, you get a whole bunch of drugs that are appropriate for those symptoms, discuss that with your patient, and then you prescribe them. The same principle applies to these type of technologies and therapies. And I think that's the problem, and we all face it.
Yeah, but I think the other side of hypnosis is actually trying to breed a different form of communication between clinicians and patients that actually engenders hope, empowers them to find different ways, because no person's journey is exactly the same as another's. And what we find is that hand-holding bridge is where I think, having gone round and round, there are certain patients who are that they're already like that. They're actually going to be slightly difficult patients because they're searching for another way to get better. And it's the people who are closed down that, are difficult. But I think it's sometimes all in a name, but it's getting your foot in the door. You're quite right. Yeah.
Well, it's the education of the doctors. It's
Absolutely.
Education of primary care, and possibly, if you can get anywhere near it, social care. Because we're dealing with frontline people who benefit from therapy, all sorts of therapies, but there's no way for them to take that knowledge of the problem and escalate it as a frontline care worker or as an agency. There is no way for us to escalate that and say, these are some of the technologies. Why don't you talk to your GP who can give you a smorgasbord of these interventions? And that's, I think, the missing bit. We're all facing it. Every individual in this room who's dealing with a product is facing that problem. How do you get the adoption? However good the technology is, how do you get the adoption?
I think it's cost efficiencies, and it's pounds, shillings, and pence these days, really, or whatever currency you work with. But in terms of making it,
Can we move on to the next presenter now, because we are a bit behind time. Our next presenter has been sitting there patiently in Northampton to join us. So I'm going to add her to the stage now.